And what I'm going to do is, earlier this morning, Tig, who works with me, he's a program analyst who supports some of the programs that I work with, sent you all 2 emails. One had all of our forms that PASSR clinicians should be aware of and use. I hope you all, everyone in this training was supposed to get it. If you did not, please put it in chat. So Ronnie, we can look, who else needs those forms. And we also send out some validated screening tools that we are recommending that you use as part of your PASSR level 2 evaluation of people with serious mental illness. So I'm hoping you all got it. And if not, we will work, Ronnie, and we'll work with Tig to see that all of you get those forms. With that said, Ronnie, can I share my screen?
Yes,
I can go ahead, right?
I think you should be able to, yes.
Correct. I know, because you send me a link as a panelist, so which is good. So let me know if you can see this.
It's coming up on the screen. It looks good.
Okay, so just in case you are here for a PASSR training today. So let's just get to the bottom of what is PASSR? What is the kind of like the acronym? It stands for pre-admission screening. And admission to what? To a nursing home. And resident review. So it's actually 2 different things all in this one acronym. So one is pre-admission screening and the other one is resident review. That's what PASSR stands for. And by the way, you will be getting this PowerPoint. So who created this program? It was established by the United States Congress. They passed a law known as the Omnibus Budget Reconciliation Act of 1987, sometimes referred to as OBRA 87. And in that Omnibus Act was PASSR. So PASSR, as you can see, has been around for well over, a good 30 years. And they passed that legislation for 2 reasons. And we're going to talk a lot about those reasons. To prevent states from placing people with mental illness and with intellectual disabilities and related disorders in nursing homes, unless they actually needed nursing facility level of care. And the second portion, equally important, it was to encourage states to create community-based services for individuals who needed this kind of support. Anyone can tell me what was like the catalyst for this? You just heard me say what the goals of this legislation were. What was happening in the mental health field around, this was created in 87. So,
when all of the state facilities started being shut down.
Why was that?
Ronald Reagan thought people would be better in community services rather than in institutional mental health facilities.
Is that Lauren who is speaking?
Yeah, that's me.
Lauren, you're absolutely right, except it wasn't Ronald Reagan.
Oh, okay.
It was John F. Kennedy.
Wow.
So it was in the 60s. John F. Kennedy, and it was then reiterated more by Johnson. They all did a huge bunch of social legislation. They created the Community Mental Health Act in 1963, which mandated that people who were institutionalized in state psychiatric hospitals, such as ours, in Salem, or in state IDD institutions like Fairview, that we needed to, the term was de-institutionalize people and bring them into more integrated community-based. That was the backdrop. Do you know why? Why suddenly they decided in 1963 to do this? What else was happening that made it possible? Anyone?
Well, Kennedy had a relative who suffered from mental health that was institutionalized, had a severe brain injury from her lobotomy, basically.
He had a sister, correct? But I'm talking more at a much larger systemic level. What was one of the main reasons why this was possible? Let me tell you, it was the discovery of thorazine.
This was also in the
medication.
This was also during the civil rights movement as well. So people were looking at their rights to not be held against their will, right?
Correct. But what was the catalyst was the arrival of medications, which was serendipitous, by the way. They were not going there to create these antipsychotic medications. They discovered them accidentally, that we realized that people could get their medications and live fairly good lives in the community, as opposed to be chained and locked up in a state hospital. So that was actually the big movement, was the arrival of these kind of medications. And so that, and all of the other cultural and social movements that all kind of came together, or there was this confluence, civil rights, women's rights, community mental health, people with disabilities, all of that. So that was the backdrop. And then what happened was the states were in a rush to observe this mandate with very little planning or funding for creating that comprehensive community-based care setting. So what happened was they had to pull people out of these institutions in a hurry, and they placed them in, where did they place them? Nursing facilities. Because they were all over the place. Now, do you know nursing facilities are considered institutions, like the state hospital? Nursing homes are not considered integrated community settings. They are considered institutions. And so that's why this act came into being, that, hey, you cannot warehouse people in nursing homes just because you have nowhere else to send them. And that's the spirit of PASSR to this day. Is this the best placement for the person? If it is, what are the services and supports they need? Do you know? So that was called trans-institutionalization. So you're taking them from one institution and putting them in another institution, which was not the spirit of the law, of the community mental health law. Do you know what we are doing today? Where are we warehousing people today with serious mental illness?
In the prisons and jails.
Yes, very sadly, we have criminalized mental illness now. And the prison system or corrections department has become the largest de facto state hospital. And for me, it's like a moral, it's a moral issue, And so again, that is an institution that is not a place for people with serious mental illness to be in. But that's where our new state hospitals are, jails and prisons. And sadly to say that the biggest mental health systems in the country are in the corrections department in Los Angeles and New York. So it's not community mental health programs. The two biggest ones are part of the corrections department of Los Angeles and New York City. So that should tell us something about how we treat people with disabilities, correct? So keep all of this in mind as you listen to OBRA. Sorry, as you listen to my presentation. So here are the purpose of PASSR: to ensure that individuals are evaluated for evidence of possible mental illness, intellectual disability, or related disorders, to see they are placed appropriately in the least restrictive setting possible, and then to recommend that they receive services they need wherever they're placed. If the nursing home is appropriate, what are the services they need to maintain their to maintain good quality of life? That is the purpose of PASSR. So for all of you who are new to PASSR, please keep this in the forefront, that this is what PASSR is about. It's not about just doing a mental health evaluation. Okay? And then further, PASSR affirms Olmsted. I know I'm kind of surprised how often people know so little about Olmsted, who have worked for years in community mental health programs. But a lot of the work we do in community mental health programs is driven by that Supreme Court decision. And it was the Olmsted decision, which was Olmsted versus LC. And what was that? In a 6-3 landmark opinion authored by Justice Ginsburg, the Supreme Court affirmed that the Americans with ADA, Americans with Disability Act, prohibits the segregation of individuals with disabilities, which includes physical and mental health disabilities. Needlessly isolating such individuals, the court wrote, is a form of discrimination based on disability. Discrimination that perpetuates unwarranted assumptions about their capabilities and their worthiness to participate in community life. The court found that institutional confinement deprives people of most of what is valued in life: relationships, social contacts, education, work, cultural enrichment, because you're locked up in this kind of institution. So bottom line, unnecessary segregation of people with disabilities in institutions, which includes nursing home, I've already told you that, is a form of discrimination, and this violates the American with Disabilities Act. I just want to tell you a little bit about Olmsted, because I love Olmsted and what Olmsted did. This case was brought forward in 1995 by the Atlanta Legal Aid Society on behalf of Lois Curtis and Elaine Wilson, two women with mental health and intellectual disabilities who were patients in Georgia State Psychiatric Hospital. They had spent most of their lives in that hospital. The hospital staff recommended that Lois and Elaine be served in community programs, but because the community services were in short supply, they remained hospitalized, or should I say incarcerated, which was a violation, they thought. Lois and Elaine represented thousands of individuals with mental disabilities nationwide who are deprived of opportunities to live outside of institutions as members of their communities. In Olmsted, the state of Georgia asked the Supreme Court to decide a central question relating to the civil rights of people with mental disabilities, whether the public services portion of the Federal American with Disability Act compels state to provide treatment and habilitation for mentally disabled persons in a community placement when appropriate treatment and habilitation can be provided to them in a state mental institution. That was at the core of the case. And guess what? They won it. And both Lois and Elaine were placed in what was then called like group homes, and they went on to flourish and thrive. In fact, one of them became a very well-known folk artist. None of this was happening when they were in the state hospital. And Lois just died a few months ago of pancreatic cancer, and she was applauded and memorialized right from President Biden down for the huge change that came about through the courage of these two women. So why am I telling you this? Because I really want you to understand, what is at the heart of PASSR. So PASSR affirms Olmsted, and PASSR affirms Americans with Disabilities Act. So it emphasized that people with disabilities have the right to live independently if they want to, in the least restrictive, most integrated setting. And that we are then, in the work we do, reinforcing the principles of ADA. Okay, so now we are coming to the meat of the presentation. So what is this PASSR, that I'm talking about? It is required before admission to a Medicaid certified nursing facility, regardless of insurance. This is not by insurance type. Anyone going into a nursing facility in Oregon and actually across the United States requires level 1 screening, which is a rough screening for possible serious mental illness, intellectual disability, or related conditions. Once that is done, if those are selected, then it triggers what we call a level 2 evaluation. For our purposes today, I'm only speaking about serious mental illness because that's the job I have at OHA. And we'll talk about the other ones later. Level 2 is a comprehensive evaluation to determine, first of all, does this person need nursing home level of care? That means being cautious that we are not warehousing that person. And if they do, what are do they need specialized services? And I will talk about that. Or what other mental health services do they need in the nursing home while they are there, so that they have good quality of life and thrive? That's essentially what level 2 is doing. It's a comprehensive evaluation. This is kind of a little icon which will show you what it is. You can see level 1 is a preliminary screen. Level 2 is an in-depth evaluation. And then the clinicians complete a legal document, which is that determination and notification that yes, nursing home is appropriate. No, it's not appropriate. I'm recommending community-based care. So this is a very kind of brief a process, workflow of how it works. And as you can see at the bottom, it says resident review we will be going into it, is also a kind of evaluation we do when there's a significant change in someone's condition who's already living in a nursing home. Okay. So again, take a look at it. Level 1 is a preliminary screen. Level 2 is an in-depth evaluation, which is what all of you on this call will do for serious mental illness. Then you complete a legal document called the determination and notification form, where you're saying, yep, nursing home is good. Nope, they will do really well in a community-based setting. So again, I'm just giving it to you in other form. Level 1, level 2 plus determination. Level 2 includes determination of placement and specialized services. And then resident review is once a resident, if there are any changes in their condition, the nursing home can request a new level 2 evaluation. I'm just going to skip this and go directly to this. So in Oregon, the oversight is provided by the state Medicaid agency, which is what? Oregon Health Authority. Oregon Health Authority is the state Medicaid agency. How have we operationalized PASSR? As you can see, there are three different ways we do so. So we have the IDD authority, who does the IDD evaluations. You don't do it, all of you on the phone, on the webinar today. We are the Mental Health Authority, OHA, and then we contract with all of you to do the evaluation, okay, and determination. So level 1 is the function of Department of Human Services, Aging and People with Disabilities, okay? And then the level 2, there are two agencies. ODDS does the intellectual and developmental disability and related disorders evaluation, and all of you on this call will do the serious mental illness evaluations. And what are they? That you will make a determination that this is appropriate, and then make all those recommendations for services. So again, I'm just reiterating what I just said. It is required before admission, the level 1, for anyone entering a Medicaid certified nursing facility, regardless of insurance or lack of insurance. Level 1, which is the responsibility of APD, Aging and People with Disabilities. It is a rough screen, and where the person completing it will select, possible serious mental illness, possible IDD, and by the way, you can have both. Remember the 2 women from Georgia, Lois, and I'm blanking on the other person's name. They had both serious mental illness and intellectual disability. So you can have both selected, but 2 different agencies do the evaluation. And I've already told you what a level 2 evaluation is. So very important for you to know that you as level 2 clinicians are not only doing the comprehensive evaluation, but you're also making that determination. So, the legislation has very clear definitions for what are considered, quote unquote, PASRR disabilities, like what mental health diagnoses are covered by PASRR. Okay, and granted, they need some updating, but when this law went into effect, they looked at like DSM-3. And in 1992, Congress kind of narrowed that definition by adding what is now known as the 3 Ds: diagnosis, disability, duration. And we'll talk about that. And I add a 4th D, which is dementia exclusion. Dementia is not a PASRR disability. Remember, this is for serious mental illness, and dementia is not considered a mental illness. It's considered a neurological illness. So the 3 Ds that Congress put into place are diagnosis. And for the most part, serious mental illness is considered schizophrenia, schizoaffective disorder, all the variations of bipolar disorder, and major depression. Those are the PASRR covered conditions. Not anxiety disorders, not sleep disorders, not most personality disorder, not substance use disorder, not dementia. Yes, dementia can co-occur with schizophrenia, bipolar disorder, that is okay, but not as a standalone. So diagnosis. Second is disability. By that they mean that this mental health diagnosis has a functional impact on their everyday independent living. They need help with medications. They need help with reminders to socialize, or they've had a profound impact on their independent living skills and on their ADL skills. That's what functional limitations means. That means their mental illness is causing a functional limitation. For example, if you break your leg, you can't walk as well without crutches. That is the functional limitation. So what is the functional limitation with schizophrenia? Can anyone give me one functional limitation?
Well, they're hearing voices and seeing things that other people don't hear or see. And that keeps them from living in the same realm.
Okay, so how would it disrupt their activities of daily living or their instrumental activity, their independent living skills, those hallucinations or delusions?
Well, the voices frequently tell them what to do, and it's not always in keeping with what they should do.
Okay, so maybe the voices is telling them the food is poison, don't eat it, or hey, that medication is bad for you. And so what happens is they're not, if they're out there on their own, they may not be able to take their medications. They may precipitously lose weight because they're afraid the food is poison. So that is the functional impact, not so much the symptoms, but what is the functional impact? And that's what PASSR wants to know, And then lastly is duration, that this has been going on for some time, at least 2 years, where the person has needed a lot of services and supports, or has had contact with law enforcement, has been houseless because they can't maintain an apartment, whatever it is, that the duration has been for 2 years. And, you need to figure out, they were hospitalized, they were in a group home, they were homeless, all of those, at least for 2 years, this kind of thing has been happening. And then I said, I'm adding the 4th D, which is dementia exemption. Dementia is not a PASSR covered disability.
Nirmala, I'm sorry
Yeah.
to interrupt you. We did have a question in the chat. Would you like to take it now or at the end?
Yeah, yes, go ahead. What is it?
We'd like to know a little bit more about what happens when a person does have both serious mental illness and dementia.
Yes.
Could you talk a little bit more about that and how dementia might
Sure.
trump other diagnoses?
Right. So that's a very good question. Again, remember I said there's a dementia exemption. However, if it is co-occurring, say with the schizophrenia or with the bipolar disorder, you as a skilled clinician need to decide which diagnosis is in the ascendance, which diagnosis is driving whatever, the current functional deficit is. Is it the dementia or is it the schizophrenia or a combination of both? If it is solely the dementia, because it is so advanced, then it would be considered dementia. And, PASSR would be exempt. So it is the skill of the clinician to kind of look at both, are they needing the nursing home because they have such advanced dementia now? Or is it that it's a combination of both? And, this new illness is kind of compounding the functional deficits. So that's what you will do.
So we would still submit one, and then they would still come out and assess, or would that be up to when we submit the review request?
If it is dementia, they can tell you this is not an appropriate referral. If it is schizophrenia and dementia, they should do some review of it and then decide.
Would that review include them coming out to see the resident, or would that?
Who is Rochelle? Rochelle, where are you from?
I'm from Avamere,
Okay.
Skilled nursing. Yeah.
So you are in which county?
Jackson.
In Jackson. So people are doing it differently. One could be if it is a resident review. I'm not talking about level 2 resident review. If you're asking them, they can do a chart review and and tell you that this looks more like a dementia. But for most cases, they should be coming out and doing it in person. And I can answer that separately. At this point, I want to move forward with the training, but absolutely, yes. So again, what is level 1? I've already told you, everyone gets it entering a nursing home. In fact, nursing facilities will be dinged, or they will get a citation if they don't have the level 1, and they're admitting people without a level 1. They cannot and should not admit people without a level 1. Okay? Again, this is not by Medicaid or Medicare. It's got nothing to do with insurance. It's the law. So whether you have insurance or not, you need to have a level 1. And as you can see, level 1 is completed by all kinds of people. APD, AAA case managers, private contractors, hospital discharge planners, hospice workers, physicians, home health, doulas, all kinds of people complete it. What do you think could be a problem with that? Anyone wants to tell me?
If they don't have any training in serious mental illness, they don't know what they're looking at, and they will see the person as, I don't know, inappropriate because of a lot of the things they say and do.
Yeah, so they are not well trained to recognize indicators of serious mental illness. And so what happens is only 20% of people get identified on the PASRR level 1. And this is nationwide, not just in Oregon, So we are looking to see how can we improve that, So many people go into nursing home without level 1 indicators, and then I get calls from a nursing home saying, Nirmala, they have schizophrenia, and the level 1 says, no, what should I do? And I'll address that a little later, which is basically that we would have to ask for a resident review, because you cannot change the level 1. The nursing home cannot change the level 1 because that is a legal document. So level 1 is kind of like a gatekeeper that identifies disability-specific needs, whether they have IDD, whether they have serious mental illness. And they have this other category, which is only a PASRR category, which they call related conditions, which are like conditions that kind of require high levels of ADL support, but they're not necessarily cognitively impaired in any way. For example, people with severe cerebral palsy, perhaps, that need nursing home level of care. So that's what related conditions are. So what happens is, it's sometimes the level 1 screen is inadequately completed. That means they have not identified, even though the person has a serious mental, for various reasons, one of them being poor training, or they don't have training in mental health to recognize it. Maybe they don't have the time, lots of reasons. And what happens is that they enter the nursing home. And what we are saying is, hey, err on the side of a false positive. If you think that it looks like they have serious mental illness, just select it. And then let the PASRR clinician decide whether it is real or not real. Okay, so the PASRR level 1 does not determine your Medicaid rate or how much the nursing home will be paid or anything like that. This is a law that you have to have it done. So it's got nothing to do with, payment of nursing facilities, what services nursing facilities will get paid for, nothing like that. So in level 1, remember I said, many of them are not trained well. What they have to look at is, does the individual have a mental health diagnosis that leads to a chronic disability? I have added PTSD and OCD here. We are looking at rewriting our rules. So we are trying to see whether we want to expand it, the serious mental illness categories, because both PTSD and OCD can be very, very disabling in terms of functional impact. Second, Has this diagnosis created significant impairment in major life activities? And third, have they had these kind of, intensive services, at least for the last 2 years, whether it is hospitalization, supported housing, jail or prison, all of those kind of things. All three indicators need to be there for a level 2 to be triggered. So all three indicators have to be there for the level 1 screener to say, yes, I think they have serious mental illness indicators. Remember, they are not mental health therapists, they are not mental health professionals. They are looking for what we call indicators. So I'm not going to go over this. So on that, they also do something called the level 1. They select something called exempt hospital discharge on that form. So what does that mean? Individuals admitted to the nursing facility from a hospital after receiving acute inpatient care in the hospital. We know that the person requires to have this kind of rehabilitation, and or the doctor certifies that they're there for 30 days or less. That's why we call it skilled nursing facility. That means they're going for rehabilitation from the hospital to the nursing facility, whether it's cardiac rehabilitation, hip or knee rehabilitation, whatever it is. That person is exempt from PASSR for 30 days. That means even if they have a serious mental illness, for 30 days, you don't do a PASSR evaluation, even if the nursing home calls you. What will be selected on the level 1 form will be indicators of serious mental illness, and they will also select exempt hospital discharge. They are eligible for a PASSR on day 31 if the person is going to be staying beyond the rehab period and or has moved to the more long-term care part of the nursing facility. So remember, first 30 days, so that's why I tell PASSR clinicians, please ask the nursing home to fax or email to you, like scan and email the level 1 form to you, so you can see what's written on the form. Because if the exempt hospital discharge is selected, then you need to write back to the nursing home and say, nope, I cannot do an evaluation until 30 days are up. Any questions on that? Did I make myself clear? So basically, this is someone coming from the hospital who's had some surgery or some event and are needing skilled nursing home care for 30 days or less. And why that magic number 30 days? Because that's what Medicare kind of covers for, rehab. So, and then the other thing on the form is called categorical determination. That form is called 460 or level 1. So the other, and I will try to send you all a level 1. I will have Ty email a level 1 where we will kind of redact the personal history so you can see the form that I'm referring to. There's another category on that form called categorical determination. And what does that mean? That means anyone admitting to a nursing home who is unlikely to benefit from a PASSR, such as the person in a coma. They're in a coma. Or they have less than 6 months to live, so they're on hospice. Or they are in a severe delirium. Those people are not going to engage with you in an evaluation, right? And they may not benefit from it. So for delirium, yes, once the delirium clears and they're stable, then yes, the nursing home can call you to do an evaluation. So on that form, that level 1 form, they can select indicators of serious mental illness, and they can select categorical determination. So if the nursing home calls you and tell you, hey, we have this form here, you need to ask, what is the mental state of this person? Is he in a coma? Is he, is he on hospice? Is he in a delirious state? Because then that PASR is not appropriate for you to do. So now we are doing level 2, which is what all of you on this call, except for the nursing facilities, the clinicians do, who are on this call today. Level 2 is the initial evaluation, which is triggered by a level 1. Remember, I said level 1, and they select on it indicators of serious mental illness. They go and you are called to do the evaluation. And then there is a resident review, full evaluation for a long-term nursing home resident. They may be there 3 months, they may be there 10 years. And there is no quota that you only get 1 or anything like that. And, so I will talk a little bit about the brief consult a bit later. So there are 2 ways to get this evaluation. One is through the level 1. Always ask for it when the nursing home calls you. And second, the nursing home can ask for a resident review, and we'll talk about it at the end. There's a whole slide deck. I have several slides on that. This is for all of you providers on the phone. This is our billing codes. For that brief consult. You bill Medicaid, and that's the billing code T2010. And for the full PASR, it is T2011. And the 643 is higher. I will definitely be looking into what the current amount. We have actually enhanced that amount a little bit more. The evaluation, the full evaluation. So that is a 643 and 7010, and I'm sure it is per service, okay, which also includes resident reviews if you're doing the full evaluation. These are the billing codes. Technically, it should be completed prior to nursing facility admission, but it is not. It is not happening that way. It is really happening in the nursing home after they're already there, which I think it will take a lot of work on our part to change that. So currently it is not happening prior. So it is happening when they move into the nursing home. So that the nursing home will call you for that level 2. Resident review is also a level 2 evaluation conducted for an individual who's already residing in the nursing home, triggered by change in behavior or mental status, both positive or negative. And then the nursing home contacts their county PASR program and asks for a evaluation. And there's a form that they have to fill out.
Nirmala, we have another question in the chat.
Yes.
What if the referral is coming from a prison, jail, or the community and the PASR-I has not been done yet?
No, so we don't go into prisons and jails. So if there's no PASR-I done, then there is no PASR level 2. Level 2 is only done if a level 1 is completed wherever the person is and they're entering a nursing home. You could be in a jail and you're needing nursing home care. They do the level 1, it goes to the nursing home and they call the PASR evaluator. So it is never done without a level 1. I don't know who asked that question, Ronnie.
Terry, does that answer your question, or did you have some more additional questions around that?
No, not quite, because I think part of the purpose is to get them out of prison and out of jail, right? And yet they're not getting PASR-Is done while they're in prison. And they're being referred directly to level 2 because that's what they need, right?
No. Level 2 is not a need. Level 2 is an evaluation.
Sorry, Nirmala, this is Andrea. So if they're coming onto an ECS unit, which is different than some of the facilities there.
They're coming from jail?
Yes.
then the APD case manager, whomever you're working with, needs to get the level 1 done.
Okay, so they're responsible for that, for the one,
Right.
and then they refer that person to us for the PASRR-II. If they're in our county.
If they're going to a nursing home, are they going
Yes.
to a nursing home?
Yes, because our I'm sorry, our ECS unit is in a nursing home, yes.
Because if they don't do it, then the nursing home will be penalized. They will have a financial penalty
Correct, yes.
for
So,
accepting someone without a level 1.
so that would be the APD
Yes.
worker that would need to do that
You
pass
can
out.
be in any setting. You can be in prison, you can be in your own home, you can be a homeless shelter. You have to have a level 1 done to enter a nursing home.
Perfect.
Whether it is an ECF program or it's a skilled nursing facility or it's long-term care, you cannot enter a nursing home without a level 1.
Right.
It is illegal, actually.
Right, and that's why we were concerned, because we were trying to figure out who's responsible in that scenario, because we've had that kind of come up. And we are working inside the nursing facility, so we want to make sure that we are being good community partners with them.
Absolutely. Talk to your local APD. And I have numbers at the back for the state level person if you have concerns that you are getting these these individuals from jails and prisons with no level 1 completed.
Perfect, thank you. We have our lady's number. I just don't know. It's just, we can help them know that that's their job, so then we can do that, help get the PASRR-II done.
Absolutely. So bottom line, nobody can enter a nursing facility, and ECFs are in, if it is in a nursing facility, without a level 1.
Thank you.
So in Oregon, there is something called specialized services. So, in PASRR, these are services that in Oregon that you as a PASRR evaluator will be recommending, and they're provided to the individual in a nursing facility, and they exceed what a nursing home can offer. So these are like services that the person needs to thrive. So I want to let you know that specialized services has a narrow meaning and a broader meaning. The narrow meaning is specialized services means acute psychiatric hospitalization. That means you go there and the person is so suicidal that you need to get them hospitalized. Or it could mean they are just so disorganized and delusional and disruptive that they need to be stabilized, and you're recommending that they are endangered, they need to be hospitalized. So that is one form. The other one is if they don't need acute hospitalization, what are those services they need to remain stable, and not just stable, but thrive? And so, the sky is the limit in terms of what you write, in your report. I also caution that you can also include staff training as a recommendation. Remember, nursing home staff are not trained mental health professionals. And so recommending a staff training on schizophrenia, or recommending a staff training on how to work with someone who's severely depressed is absolutely something that you can recommend in your evaluation. In Oregon, we have identified that the level 2 evaluation for serious mental illness has to be completed by a QMHP, which means that you are, for the most part, a master's prepared clinician. There are some very rare exceptions where people have been grandfathered into this QMHP process. But for the most part, you are QMHP, you are certified QMHP. They are the folks who are doing this evaluation, master's prepared or higher. This is an extensive evaluation, which includes kind of the whole spectrum, biopsychosocial functioning, to determine if nursing home is the most appropriate level of care for this individual. But at its heart, it is a powerful document that synthesizes, evaluation to educate the nursing home and other providers about the service and support needs for this person. And that should then serve as a basis for their care plan in the nursing home as it pertains to their mental health. You're telling the story of the individual. You serve as the person's voice frequently. And very importantly, you identify what are the supports and services they need. So for level 2s to be effective, this is what you have to do. Does it accurately determine the need for nursing home services? Does it accurately identify appropriate specialized services? Does the evaluation identify individual services and supports? Does it engage the individual as an equal and valued partner in the assessment? Is the report individualized and detailed and not like a cookie cutter out of your EHR? Did the evaluation ask the right questions to know what is important to and important for this person living in the nursing home? And we talk all the time about person-centered PASRR. What is important to the person? What does he enjoy? What makes a good day? What helps when symptoms are bad? You know, what are their goals? What's important to them? Like the what matters to you question. So you conduct, what are the elements? You conduct a professional, individualized, and comprehensive evaluation. This is done in person, in the nursing facility, not by telephone, not by video. Yes, during the pandemic, we had special federal dispensation, to do that because nursing homes were locked down. So this is an in-person. You have to actually go there. You don't need release of information or consent. The law doesn't require you to do that. You can go there and meet the person. If the person doesn't want to meet you, that's what you need to report in your evaluation, that you met with the person, but they refused to engage with you. And so then you will talk about where did you get your information, and you will say, sources of information for my evaluation came from chart reviews, talking to the LPN, the administrator, the family members, whatever. But you do not need consent for treatment. You have to do face-to-face. You need to gather all of this comprehensive information, and then you create the document, which is, hey, this is, and you have to recognize this is a PASRR disability, and then you do what all we've been talking about. This is what I was talking about when I talked about the person-centered PASRR. Tell me what matters to you. And so really the lens is values, strengths, capabilities, and contributions. Given the choice, I'm asking all of you, what would you choose for yourself or for your loved one? Historically, we've thought, how have we historically thought about recommendations? Compliance, clinical stability, improved judgment, insight, reduce aggression, follow recommendations, decrease hospitalizations, improve cognition. Or do you want to look at a facility where we talk about life worth living, connection with others, to be a good mom, daughter, sister, brother, have friends, have fun, cultivate hobbies, learn about social connection, hope for the future, joy, giving back, a home? You tell me which of these two facilities you'd like to be in, or you'd like to place your mother in. That's what we want to capture in our assessments. So you need to be writing all of this, who the person is, what are their important relationships, what is their history, what is their hopes and dreams, how does their symptoms impact a good day and a bad day, and what can nursing home staff do to help with that in terms of what's working and what will not work. So it reinforces a culture of using and empowering individuals' abilities and preferences over disabilities and limitations. You know, nursing homes can be very medicalized. You know, they're looking at medical diagnoses, medical, interventions. Well, this is the person's home. Adaptation of the individual's capabilities rather than their inabilities. That's what you're going to focus on. And, you know, I'm preaching to the choir here, but people are more than their disabilities. I always talk about the person and not the symptom. Emphasis on the person first, disability second. Help maintain the integrity of the individual. Supports individuals' ability to self-direct services to whatever extent they can. And to use first-person language. Not that he's a schizophrenic. That's an alcoholic in my nursing home. That is not first-person language. That is not the person's their illness is not their entire identity. So here are some things that you do in level in level 2. You know, you collect all of this data, medical, psychosocial, drug, medication, any kind of psychiatric evaluation, what kind of functional assessments have been done, you know, whether they have gone to a neurologist or, you know, they're getting physical therapy. So it's, as you can see, very, very comprehensive, you know. Once all of that is done, who do you send that notification to? You send it to the individual or legal representative, to the nursing home, to the physician, and to Oregon Health Authority. And we will be going over that form. So you have to write all of this in an evaluation, you know. We specifically want you to include personal characteristics, skills and talents, and specific limitations and needs, because that will tell the nursing home, you know, where they need to build the services and supports. So it needs to be a really practical document, not a cookie cutter document. I am recommending that all of you use all of these standardized screening tools, and Ty send you copies of these tools this morning. Screen for cognition using slums. And this is for anyone that you're going into a nursing home to do. Just do the slums and then screen for depression and anxiety. Screen for social isolation and loneliness. Be certain to comment on the scores for for these tests and make appropriate recommendations based on it. And then I have asked all the PASRR clinicians to recommend annual assessment for vision and hearing for the resident that you're meeting with. Check if they are actually have hearing loss and if they can hear properly and if they're using their device, or are their glasses clean? You know, they can look through their glasses. Are they wearing them most of the time? That's all part of your evaluation. And I'm just giving you why I'm talking about hearing. Older adults with hearing impairment tend to have poorer physical function, less walking endurance, faster decline in physical function. Can you see how important it is? And sometimes you're the only one making that kind of connection. It can also lead to decline in cognition, depression, and social isolation. And because hearing impairment is amenable to prevention and management, it serves as a great target for intervention to slow down physical decline and improve quality of life. You know, you will get this, my PowerPoint. I'm just giving you some examples of, you know, what should go into unique personal characteristics, skills and talents, or limitations and needs. You know, you can talk, she's a painter, she loves to craft, She's an avid reader. She likes to read travel books. I mean, anything you can write in talents, skills, all of that, and limitations she needs help with. She's at risk for falling. So maybe, help her with this, whatever you need to be writing that in your report. And always balancing what is important to the person and what is important for the person. Very often we focus on what's important for the person. That's why this needs to be a collaborative assessment. Address all aspects of well-being, not just symptom control and keeping them out of the hospital. Their identity. Is their identity celebrated? Are they do they feel connected? Remember I said screen for social isolation and loneliness. Security. How safe do they feel in this place?
Hello?
Who's that? Hello? Is someone not muted?
Prudence, were you trying to ask a question or add something?
No, ma'am. I'm trying to do several things at one time.
That's okay.
I'm sorry.
No worries. I'm going to put you on mute, but feel free to come off mute if you would like to add something later on.
Okay, thank you.
Thank you. And Nirmala, we do have a question in the chat as well. Would the DLA-20 be required or recommended, or is there another option for ADL evaluation?
No, DLA I wouldn't recommend for this group. For another ADL option would be, we don't really, ADLs are not our strong suit. So you can find out what are the ADL needs. Do they need, toileting help or whatever? But more importantly is IADL. So Lawton is an instrument we use. How do you support autonomy in your report? Meaning and purpose, growth, joy. So you're addressing all of this. Very often in nursing facilities, we focus on the bottom two rungs of the pyramid. Are they getting food? Are they well hydrated? Are they taking their medications? And are they safe? They're not falling out of the bed, and people are not beating them up. Or, we try to keep them away from aggressive people or other residents. But we fail to do anything beyond that. Do they feel a sense of belonging? Are they connected? Do they feel part of a community? How are you supporting this self-esteem? How are you continuing to promote self-actualization? Their creativity, their sense of accomplishment and joy. That's all part of living in a nursing home. So what should the level 2 do? Confirm or disconfirm the PASRR diagnosis? Go beyond just compliance, I have to do it, that's required. But really make this a living document that makes sense to the resident and the nursing facility. Describe in details what supports they need. And then make clear treatment recommendations. And by clear, I mean by whom, where, how, give telephone numbers, actually write, this is the address to take them to this senior center for a grief group, whatever. Very clear. Okay. And again, here, I'm just saying, for example, local senior center to attend a grief support group. You can absolutely make that recommendation. Or the older adult specialist is leading a book club. I would recommend that this person join the book club. Here is the web link or whatever. I'm giving you an example. So think about outside the box. Don't only think about skills training and this and that. There are a lot. Remember, nursing home is their home. What do they need to really thrive? And I always, and if you think they need an occupational therapy assessment or a physical therapy assessment, it is absolutely within your scope as a QMHP to make that recommendation. When would you make a physical therapy assessment? Maybe you're seeing that they can't walk really well. They're kind of, they feel jittery, or their balance is not great. You can mention that in your observations, in your mental status, and then make a recommendation to explore physical therapy for this person, and give some rationale, so that their mobility is improved, and mobility is definitely connected to mood and all of that. So balance quality of care and quality of life.
Nirmala,
Is there anything else, Ronnie?
just to clarify, would you please repeat the name of the alternative IADL assessment you mentioned?
LAWTON, Lawton. I
Thank you.
don't know, Ronnie, if you want to just put it in a chat, or even if you want to put a link in it for the Lawton
Sure.
IADL, that would be great.
Okay, thank you.
What is a resident review? A resident review is triggered when an individual undergoes a significant change in status, and that change has an impact on their functioning as it relates to their mental illness. Okay? So now there is no annual review. Before we used to do annual review, now there's no annual review. However, nursing homes can ask for a resident review by completing the appropriate form. Why is this not moving? Okay, here is an example. A resident demonstrates increased behavioral, psychiatric, or mood-related symptoms. They're crying, they're not eating, they want to die. They have not responded to treatment. A resident experiences an improved medical condition. A resident whose significant change in physical, but with behavioral, psychiatric, or mood-related symptoms or cognitive symptoms that may influence adjustment. A resident who indicates a preference to leave the facility. So lots of reasons to make referrals. They have improved, they are worse, the treatment is not working. Any of that, nursing homes can ask for a level 2.
Can I add that we are giving medication by injection with a lot of clients, and I've got a client that she only gets a shot twice a year instead of every month, and she is really doing well in the community, and she hadn't done well, and I would suspect that you'll see some patients that you need to review that are doing well because of something like this.
That would not be a resident review request. The resident review request would be that they have been stable for so long on this new medication regimen. Is the nursing home actually required now? Can they live someplace else?
Yeah. So they wouldn't get a review?
The way the review is asked, that they're stable for 2 years, they have very minimal ADL care needs, their mental health is well controlled by IM medications, maybe they need to be looking at another placement. Yes. Not so much is the IM medications working, because QMHPs, that is outside their scope of evaluation. But is the placement, do they still need to be in a nursing home? Because remember, we have to respect Olmsted and ADA. By the way, I forgot to mention, the level 2 evaluation is also co-consulted on and co-signed by a licensed medical provider, which is a psychiatrist or a psychiatric nurse practitioner, that they comment on the medications, on the labs, on the physical and history. In Oregon, that is required. Okay. So do you need to do a resident review when an individual is transferred from one facility to another? If a person goes to another facility without an intervening hospital stay, it is not considered a new admission, so no resident review is required. If it is, just to a different nursing facility. So again, I've told you, what all should be included. It should not just be done, as a compliance thing, as a cookie cutter template. It really needs to be person-centered. And I always tell my PASRR clinicians, you may be the only mental health evaluation they may get. Here are our resources if you want to take a look at the OARs. We are rewriting our rules. So once they're updated, we will let you know. Here is the contact information. So I am responsible for SMI level 2. We have our webpage, Oregon Health Authority's webpage. I'm hoping to put these, maybe we'll see how to put these screening tools up there too. For level 1, please contact Catherine Nunley. And then for level 3, you have to send, for IDD, sometimes you may be asked or it's inappropriately sent to you. You need to tell the nursing facilities that they need to send a request through that inbox under Rachel Olson's name. Lastly, if any of you are so ambitious and want to know more about PASRR, there are lots of good webinars recorded and kept on this website called PASRR Technical Assistance Center, also known as PTAC. With that said, I have finished my training in good time, and we have like 10 minutes for questions, interactions. I never knew this. This is all new to me. Anything that you would like to ask. If you'll have cameras, I'd appreciate if you can turn it on. If not, I understand Terry and all don't have availability of cameras. So what are your questions or thoughts or?
So Nirmala, this is Terry. I'm just curious of the priority or the protocol with getting a PASRR-II for IDD and mental illness. Does one precede the other? Does one trump the other?
We are responsible for IDD. There's nothing about trumping in one or the other. If both of them are selected, we do 2 of them. You are not responsible for IDD. You just proceed to do your SMI. And it needs to be done within 7 to 9 days of the referral being made.
Okay.
So we can help the care center in the future. So if we have somebody with both of them dual diagnoses marked for both, then they need to make sure to reach out to both parties.
And I've given you the information where they need to reach out to IDD.
Yes, absolutely.
Yes, yes. But it's not your responsibility to figure out what trumps the other. Yes, you can write in your evaluation that they also have a co-occurring intellectual or developmental disabilities. If they have Down syndrome, you will write that they have Down syndrome, in your mental health evaluation. But did you know 40% of people with IDD have a mental health diagnosis? Often under-treated and under-recognized, which is an inequity.
Nirmala, we also, oh, I'm sorry, go ahead.
No, yes, Ronnie, what were you going to say?
We have another question in the chat. How long should it take for the facility to receive a level 2 back?
You have to see the person within 7 to 9 days, and you have to complete the level 2 determination form, which you all received by email within that time frame when you're there, 7 to 9 days. The evaluation, which is a full comprehensive report, can take up to 30 days. But the determination form has to be completed within 7 to 9 days. And
Thank you.
it's in person. No video or phone contact here. Unless, there are some nursing homes who are even currently on lockdown because of COVID or something. That would be the only time that you would try to do like a video or something else. So otherwise, the expectation is in person. Any other?
Yes. Hey, Nirmala, this is Kay. You mentioned that the PASRR-II evaluation is reviewed by either a psychiatrist
Yes.
or a mental health nurse practitioner.
Yes.
And my question is that the responsibility of the evaluator to contact those individuals, to send the reports to those individuals?
Is the case the responsibility in your case of Lane County Health. They have to create that dyad for whoever is going to be the PASA clinician. So they all know, hey, once I complete it, I have to talk to this psychiatrist or this nurse practitioner. They have to comment. Some of them write reports, small reports on medications, labs, recommendations. Yes.
Okay, very good. Thank you.
Yes. Any other questions? Well, I know some of you are brand new and coming in to listen to what's required. I'm hoping I've kind of clarified, in somewhat, clearly now you have a clear idea, what it is. For it, one thing I didn't mention was if you get someone with a dementia diagnosis and you go, they're saying mental health, you go there and find out it's dementia, you can write a brief consult. Which is a shorter report where you just say, this person's primary diagnosis is dementia. It is not a covered diagnosis. However, here are some recommendations for their behavior or whatever, and then you build that brief consult.
Nirmala, of course, we know that as our population ages and people with behavioral health conditions are developing cognitive impairment at a much greater, much younger age than the general population. And so the likelihood of seeing someone who has been approved for Medicaid long-term care services through the aging system, someone who has a historical behavioral health condition, and it is morphing into a cognitive impairment. We know that this is a big issue in our realm. So there's going to be a thin line there.
That's where the skill of the clinician will come forward, that you will have to ascertain, is this a dual diagnosis, like both schizophrenia and dementia? So I need to be involved and give recommendation. Is this purely now dementia? That means their schizophrenia was stabilized for years. Now all of these behaviors are new and really look more like a dementia. So you are looking at what's in the ascendance. Or is it not? They're both happening at the same time. So that's the skill of the practitioner to make that recommendation then. And then you would say, hey, here are things to continue to do for the schizophrenia diagnosis, and here are things that you may need to do for the new dementia diagnosis. Absolutely.
Thank you.
And by the way, I have a ton of PASA clinicians who call me up, Nirmala, I'm stumped. I don't know what to do. I don't have that level of skill. Can you help me? And so, to the best of my ability, because I have many other programs that I'm managing, that if I'm available, I absolutely make time to talk to those clinicians and walk them through some of the things which they may have missed, kind of looking at, or don't have the knowledge or skill level to kind of discern. I'm just curious, Ariane, any questions from you as a manager for, that who's looking, who's looking at PASSR programs?
I don't think so, but we've gotten a lot of support from PsychMed, who's been doing these for us in the last decade. So I got a lot of questions answered from them yesterday.
Okay, good. Mhm. Anything else? There is nothing. Go ahead.
Did you say you were going to send out the alternative assessment tool too?
Ronnie was going to put it in chat.
Oh, okay. Thank you.
Yeah. The other assessment, screening assessment tools you'll got by email. If you did not, please reach out to Ronnie. Then Ronnie, you can connect with Tig, or the email, you must have been on it, that you can follow. If you did not receive both the forms and the assessment tools that I mentioned in my in my presentation, we actually send you copies of those assessment tools. You're welcome to download them and take them to the nursing home and complete them when you see when you meet with the resident. Okay, well, you all know my email. It's there on the PowerPoint. You will be receiving this PowerPoint presentation. Ronnie, I will send it to you, and if you want to send it out to people who attended today. And you can always reach out to me with any additional questions, or if you're going out to do an evaluation and you're stumped. So.
Thank you so much. I'll be sending out that email. I'll also include the lot in IADL in the email too, so that you all have that handy. Nirmala, thank you so much for the training today.
Thank you. Bye.